Good afternoon, everybody, and thank you for joining us. We're going to go ahead and get started. We've got a lot of material to cover today. We might run a little bit long, just a few minutes. Dr. Tillotson has a ton of information, and I know we try to pack in a lot to these 30-minute sessions. So if you have to leave right at 1 o'clock, go ahead, and if you have any questions at all during the process or what happened afterward, you can always let us know or check out the recording at the end. For those of you who are listening live, there is a Category 1 AMA PRA credit offered for this recording. You can get that survey at the end, and I'll remind you guys of all this. You can get that CME credit by doing the survey that's in the calendar appointment with the login information. If you're listening to this as a recording, you will find that same survey in the notes section of the YouTube video. So both the live and recorded versions of this qualify for AMA PRA Type 1 credit. As you know, when you logged on, you heard that the conference is in silent mode. That means we have muted everyone's phones until the very end. If you do have a question, you can go to the participants list, which is at the top right-hand corner of your screen. Click on that, and then have a little login that says Ask Questions Here. If you type in your question to that, just to that one participant, it'll come straight to me. I'm monitoring on a side computer, and I can ask. I will try to hold those questions until the end unless there's something about a specific slide or a comment that you'd like to make. Just a quick shameless plug here for our other work that we're doing. We do offer these neonatal and pediatric focused CME webinars, professional network. We have our perinatal readiness program where we go out and actually teach how to do stable and OB and emergent delivery stabilization, things like that through the class. You can find all of our recordings on our YouTube channel. If you just search in the YouTube box for Carilion Children's CME or Carilion Children's Outreach, you'll find our YouTube channel. And then we also have our clinical quality programs, patient follow-up programs, transport reviews and debriefs and things of that nature. So if you ever want to get in touch with me to follow up on one of those programs or to suggest a topic or something that we can cover in one of these lectures, here's my contact information down here. Today's presenter is Dr. Cara Tillotson. She is a DO, and she is currently a pediatric hospitalist at the Carilion New River Valley Medical Center. She covers the newborn nursery and the new Carilion Children's Peds floor that is there, as well as some ER consults and things like that. Last year, she was serving as our chief resident in our Peds residency program here at Carilion Children's, where she split her time between being a hospitalist and working in that program and working in our endocrinology clinic. So that's kind of where she has developed a love and a passion for all things endocrinology and why she is going to talk with us today about DKA. So with that, I'm going to turn it over to her. Thank you all very much.
Okay, thank you everyone for joining us. I first want to mention I don't have any financial disclosures, but I'm going to refer to some insulin pumps by their brand name because they don't exist as generics, and I want you all to be aware of some of the names that parents might use. My objectives are mostly to discuss the initial management of DKA and really focusing on emergency room or clinic management and appropriate disposition based on the severity. And then at the end, I want to go over some common pitfalls we see as inpatient providers that when patients go through outside EDs where they might not be as familiar with pediatric management. So here's our case. She's a super cute girl. 10-year-old girl with known type 1 diabetes comes to the emergency room with 6 hours of vomiting and abdominal pain. She's really not been able to eat today. She's taking some fluids, but not much, and her blood sugars have been running high, about 250 to 300. At home, they were checking urine ketones, and they've been moderate to high, so family has been doing her sick day guidelines. But recently, she's not been able to keep her fluids down, so they called their endocrinologist who said, go ahead and go to the emergency room for evaluation. So what is DKA? As most of you probably know, it's classified by hyperglycemia, hyperosmolality, increased lipolysis, which causes the ketonemia and ketonuria, and then metabolic acidosis, a gapped metabolic acidosis. The cause is the lack of insulin or an increase in the counter-regulatory or stress hormones in times of things like illness, trauma, sepsis, things like that. I do want to focus on this cause here. It's the lack of insulin or the stress hormones that cause the DKA, not the hyperglycemia itself, and that can be confusing to some people. But remember, the hyperglycemia is a side effect of not having enough insulin. Then you get into this bad cycle where you lack your insulin, you get hyperglycemic, that leads to an osmotic diuresis because your body will try to compensate by urinating out the glucose, which causes more dehydration, and then that causes an increase in your stress hormones, and you get into this higher hyperglycemia, more osmotic diuresis, and you can see how you can get stuck in that cycle if you don't correct it early enough. DKA is still the leading cause of morbidity and mortality in children with diabetes. The children do still die from this, and they do still get serious permanent complications if it's not treated appropriately. Luckily, that's rare. It can present in type 1 or type 2 diabetes in children. So this is very different for children compared to adults. Yes, adults with type 2 can also get DKA, but I think a lot of people aren't yet aware that type 2 diabetes is increasing in the childhood and adolescent age range, and up to 25% of patients who have type 2 diabetes will initially present in DKA, and that's a really big number. Causes, obviously, new onset diabetes is kind of the classic one. Noncompliance, either intentional or unintentionally skipping insulin doses, not understanding their home insulin regimen. Acute injury, surgery, illnesses, especially ones that cause that vomiting and like flu or gastroenteritis or bacterial infections that could push you into that bad cycle. Pump failure or pump site failure, or expired or bad insulin. Remember, people sometimes leave their insulin out in the car and it gets really hot or freezes, or it just expires and they didn't realize it. So kind of the classic presentation, it might be an initial presentation of new onset diabetes, or it can be in a patient with known diabetes who's undergoing stress, and they come in and they know that they're going into DKA, and then that's very easy to recognize. Classic symptoms, of course, polyuria or nocturia in a previously potty-trained child, polydipsia, polyphagia, weight loss, and fatigue. Kussmaul breathing, that is that short, rapid breathing, that shallow, rapid breathing that children can get when they have metabolic acidosis, and it's a compensatory respiratory alkalosis, and typically their lung sounds are clear. Dehydration, vomiting, abdominal pain, and then in more severe cases, lethargy and altered mental status. But it's important to know that you can be tricked into missing DKA, especially with new onset diabetes. It mimics a lot of really common conditions, and we always hear these stories of somebody who went into the office, was diagnosed with strep pharyngitis because they had vomiting and dehydration and weren't feeling well and abdominal pain, and then they come back a few days later in severe DKA. So always keep DKA in the differential for patients who have flu symptoms, viral gastro symptoms, strep. Remember, kids, or adults in that matter too, can be carriers of strep, so that false positive on a strep screen might not be the real cause of symptoms. A urinary tract infection with the abdominal pain, and then pneumonia or asthma. Remember, the tachypnea could be due to Kussmaul breathing and compensation for metabolic acidosis. So it is worth it if you're even questioning it a little. A really quick test is a UA. You're going to see glucose and ketones if they have DKA, and then you can manage them from there. So now you suspect DKA, what labs do you want to get? So the basics, obviously you need to get a BMP or electrolytes to look at your status, a UA to look for glucose and ketones, an ABG or VBG to look for acidosis, although some places don't get that initially. You can get blood beta-hydroxybutyrate, which is the ketone that's produced in DKA, and some institutions will use that to assess the degree of DKA, although we don't typically use that here. You can get a CBC if you're concerned about an underlying infectious process like sepsis, but remember that the white blood cells are probably going to be high due to the stress of DKA, but also because of dehydration. And if you're concerned they might have a concurrent lactic acidosis like in sepsis or hyperosmolar hyperglycemic syndrome, you can get a lactate, and that'll help you differentiate. Now, if you want to be really nice to your endocrinologist and somebody who's a new onset diabetic, it's really helpful to get some labs before you start insulin. So antibodies, the three that are classic for type 1 diabetes would be the anti-insulin, anti-GAD, and islet cell, but this anti-insulin you can't get after you start insulin because you're going to have them and they'll be false positive. And A1C is helpful because it's going to assess the long-term hyperglycemia, so you can help differentiate, for example, a stress hyperglycemia from really severe maybe sepsis or infection from true diabetes if the picture is not clear. And an insulin and a C-peptide level, if you're concerned for type 2, You can get this before given insulin as well. A lot of people think these have to be fasting, but they don't necessarily have to be as long as you have documented a glucose at the time, because you want to compare whether or not these levels are appropriate for the level of glucose. And then a TSH or free T4, because thyroid disease is very common among people with type 1, and so a nuance that just going ahead and getting that lab and saving the kit a stick is helpful. But keep in mind these could be altered because of the acute illness. So your classic presentation, you're going to have a gapped metabolic acidosis, ketonuria and ketonemia, and glucosuria and hyperglycemia. Those are kind of the requirements for DKA. Your potassium is likely initially going to be normal or slightly elevated, but there's an overall potassium deficit that we'll talk about in a little bit. Just a reminder of how to calculate your anion gap. It's sodium minus the combination of chloride and bicarb, and greater than about 12 to 14 is considered a gap. But you can have that concurrent lactic acidosis. So if you get a bicarb back that's really, really low, but there's not a gap, you might consider that they may have diabetes and lactic acidosis, because this won't cause an anion gap acidosis typically. And just a side note, remember you have to correct your sodium for glucose. So hyperglycemia causes false low sodium levels, and so this is a calculation for calculating corrected sodium. I recommend not putting this in your memory bank and just using a search engine and finding some calculator online, because there's a lot of easy ones where you just plug in the levels. So our case, our little 10-year-old, her initial lab shows large ketones and glucose greater than 1,000. Remember that the urine glucose is always going to be higher than serum glucose, because your renal threshold is 180 and you're going to have a huge amount of glucose out. Her BMP shows a sodium of 143, potassium of 4.6, chloride 102, nothing too crazy. Her bicarb is low, she's 16. Her BUN is high at 20, and her creatinine is 0.7, which is acceptable, but probably on the higher side compared to her baseline, showing that she's probably pretty dehydrated. And her glucose is 315. So when we use the corrected sodium for her 315 glucose, it's actually 145, and we plug that in for her anion gap, and it's 27, so she has a gapped metabolic acidosis. Pretty big gap. So I want to go into management now, and I think we can't understand ED or inpatient management without first talking about the outpatient management. So patients who are on insulin who have diabetes, if they're on injections, they're typically giving multiple daily injections. So that means doing a long-acting insulin as a basal once or twice a day, and that would be your glargine Detromir, or the new one is the, I can't pronounce it, probably Deglutic. I know the brand name, but don't want to endorse anything here. Those are going to be your basals you use every day, regardless of if you eat or you don't. You need that little bit of insulin to mimic the pancreas's innate insulin production. And then you give short-acting insulin for meal coverage and blood sugar corrections multiple times a day, and those are your Lispro, your Aspart, and your Glulisine. Now, typically families are going to know a carb ratio and a correction factor or sliding scale. So you might hear them tell you these numbers, and I wanted to make sure everyone's familiar with what this means. A carb ratio basically is the amount that they give when they eat their carbs at their meal. So for example, they're going to give 1 unit of insulin is going to cover X number of carbs, 10, 20, 30. They would count up their carbs, and then they'd give a unit for each amount. The correction factor, or the sliding scale, can be thought of as doing the same thing. Typically a correction factor is if you have a pump, and a sliding scale is if you don't, but we see both on both types of patients. And this is basically the amount your blood sugar is going to go down with 1 unit of insulin. So for example, 1 unit will cause an 80 milligram per deciliter decrease. And a common sliding scale that you're going to see is, for example, 1 unit to every 50 milligrams per deciliter that the blood sugar is over 150. So that's what patients are referring to. And most patients and parents know their ratios, and I will tell you they should know their ratios. They may not, especially if they have a pump, but ask them, because that's going to help you and save you a ton of time in trying to calculate what dose to give them once you're trying to transition them to sub-Q. And children may be on metformin if they have type 2 or they're insulin resistant, and remember metformin rarely can cause lactic acidosis. All right, I want to talk about some of those scary pumps. When I was here in Roanoke, I used to get a lot of phone calls coming down to the ED to look at pumps. They are these small devices. I have pictures of them in just a minute. They infuse continuous short-acting insulin throughout the day. So patients bolus insulin for meals. They manually enter that information, and they do that for their correction doses or their sliding scale. But then there's a background basal that's set in the pump that automatically gets delivered, and that's a small amount of short-acting insulin that's given all of the time. These patients do not have any long-acting insulin on board. So if their pump site fails or they don't put it back on or they don't fill it up with insulin, they can go to DKA rather quickly because their short-acting insulin is really only going to work for about 3 hours compared to those who are on long-acting insulin lasting a full day or so with a little bit of insulin in the background. And remember, it's the lack of insulin that causes the DKA, not the hyperglycemia. All pumps have a help center phone number listed somewhere on the pump. So ask your parents if you're concerned that the actual pump is failing, but usually it's not the pump itself, it's the site. So patients who have DKA and are on pumps at home should suspend or disconnect their pump when they arrive to the ED or the hospital and change the entire pump site. So I'll show you a picture in just a second of that. And they need to change their insulin to a fresh and unopened bottle to make sure the insulin itself wasn't the thing that was causing the problems. If you're uncomfortable with pumps, it is super reasonable just to switch to subcutaneous injections while they're in DKA and work on getting the pump back on only when the DKA starts to resolve and you're thinking about sending them home. Pumps are complicated. Many families don't know all of the features of a pump, and if you can't get a hold of an endocrinologist or you just are having difficulty looking through the pump, it's totally fine to switch to injections. So here are some pumps that are on the market. So most of them have tubing. So these are Medtronic pumps, 2 different types, and this one's the T-Slim, and they're very popular. And you can see they have this tubing and this infusion site that goes into the abdomen or the buttocks or the arm. When I talk about changing the entire pump site, that would mean getting a new syringe, new tubing, and a new infusion site. And the insulin is in here, so the syringe goes in here, and then it delivers it continuously. You can get an air bubble in this tubing, and that could cause a lack of insulin for the amount of time that the air bubble is there, and that could also cause DKA. This one is an Omnipod. A lot of children have this, and it is, as you can see, cordless, and it's controlled by this little PDM. So you want to look through there if you're looking for doses or anything like that. All of these are fairly intuitive if you want to go through it, and you will be able to find settings for things like insulin to carb ratio and correction factor. So that could also help you if the parents don't know them. Our case. So the patient's mother says, you know what? She changed her pump site just before these symptoms started, a few hours before. And you, being very astute, you say, can you remove that infusion site? And you see this. So you see this kink. So when this girl inserted her infusion site, something went wrong, it kinked, and she's not been getting any of the insulin that she's thought she's been getting, she's been bolusing for. So you suspect that this was the cause of the lack of insulin and DKA. So management. Children are not little adults. I know we all hear that, but I want to emphasize it for those who might not deal with children in DKA frequently. The fluid management is different than adults because these children have an increased risk of cerebral edema. Cerebral edema is very serious. The exact mechanism really isn't totally clear, but we do know it's due to rapid correction of acidosis, sodium, and glucose, and due to excessive fluid resuscitation. Even children who look like adults, so your adolescents, are still at an increased risk of cerebral edema compared to adults. And they think this has to do with the immaturity of the blood-brain barrier, but nobody knows for sure. This is rare. It only occurs in about 1% of patients with DKA, but the mortality is really high. So 40 to 90%, depending on which study you look at, of children who develop cerebral edema will die from it. And there are still cases of kids who get permanently disabled from this. So you really want to be careful. Risk factors, younger age, so less than 5, if they're new onset diabetes, because they are likely going to have a longer chronic acidotic picture, severe acidosis, severe dehydration, and then higher serum osmolality. So initially, the way you prevent cerebral edema is by being judicious with your fluid management. So you want to give a 10 ml per kg normal saline bolus over an hour, which is slower than you would typically do, and you could repeat this once. After that, you're going to put them on maintenance fluids. And I recommend consulting your hospitalist or PICU doctor to determine their preference because there's a lot of ways to skin this cat. But in general, you're going to start with a normal saline and potassium. Don't go over 2 times maintenance IV fluid rate. You're going to assume about a 6 to 10% dehydration, and typically this will end up in being about 1.5 maintenance. And make sure you recheck your potassium after the initial fluid boluses. If they're normal kalemic and voiding, they usually need about 30 to 40 MEQs per liter of potassium, depending on how acidotic they are. So who needs a drip? We see this all the time where patients that are in mild DKA get put on drips, and that's not necessary. Moderate to severe DKA or a bicarb less than 15 is what we use here to determine who needs a drip. And you start that drip at 0.1 units per kg per hour. In our institution, these children all go to our PICU. Some places they'll go to a step-down unit, and some places will do this on the floor if they're in, just if their bicarbs maybe 14 and they're expected to correct okay. But you do need to monitor these patients very closely for things like cerebral edema, and you need to check their blood sugars frequently because they could have a rapid decline. And we'll talk about giving dextrose-containing fluids once the blood sugar starts to drop. Mild DKA with a bicarb of about 15, this can be managed with IV fluids and subcutaneous insulin. So you usually are asked to start a long-acting insulin in the ED and give a subcutaneous rapid-acting, but remember not to give IV insulin boluses because that can cause a really rapid drop in your glucose, and we don't want these kids to correct too quickly. These mild DKA patients are usually appropriate for floor-level admission if they're otherwise medically stable. All right, potassium replacement. So remember back in physiology, cells are just bananas floating in salt water, right? So patients overall are going to have a potassium depletion, but the initial labs are going to show a normal or high potassium because with the lack of insulin, potassium is concentrated extracellularly. So when you correct the acidosis, the insulin will drive that potassium into the cell, and then that potassium is going to drop. So you want to put potassium into the fluids based on the serum potassium initially, or excuse me, after, initial or after you give a bolus. And this is what we use here at Carilion. So if you have initial of 3 to 4, you're going to do 40, which is your highest, and then all the way down to 6 to 7, you would do none. The 2-bag system is something we use here for patients who are on a drip or if they're NPO for whatever reason, either throwing up or can't tolerate PO or just not waking up to eat. Glucose, your hyperglycemia is going to correct before your acidosis does. And it's important to continue the insulin because that's what's going to close the gap and that's what's going to treat the acidosis. So you can hang 2 IV bags in order to prevent low glucose. So you're going to have one that has dextrose in it and one that does not. And you're going to adjust the fluid ratios based on blood sugar. So here we use a blood sugar greater than 300. You're giving everything through the normal saline with potassium. If it's 2 to 300, you're going to run half of the total rate of the normal saline and half of the total rate with D10 with potassium. And if their blood sugar is less than 200, you run only the D10. So example, our patient's 30 kilos, so her 1.5 maintenance rate is 105. So if her blood sugar is greater than 300, that entire 105 is coming from the normal saline with potassium. If it's 2 to 300, then 52, technically 52.5, is coming through the normal saline with potassium, and the other half is going to be D10. And if it's less than 200, it's just D10. Now, if they are eating, you don't have to give any D10 so long as they're taking in glucose that you can then give them subcutaneous insulin for. Monitoring is going to be different based on your institution. You typically want to do a blood sugar every hour initially and an ABG or BMP every 1 to 2 hours, depending on how severe they are. And remember always to check the glucose and the BMP after the initial fluid bolus because the glucose is likely to drop quite significantly just with fluids, and possibly the degree of acidosis could change, and that could go either way. Some kids get more acidotic and some get less. I frequently get asked whether or not patients can go home who have DKA, and the answer is yes. If they have mild DKA, it resolves the ED treatment, and we had a source or we don't expect it to be, for this person to have vomiting at home, you can go home. You got to make sure they're tolerating fluids so they can keep treating with their sick day guidelines. Most kids who have diabetes will have these sick day guidelines from their endocrinologist. But basically, they have to check their urine ketones, check their blood sugar, and give a correction dose about every 3 hours, drinking lots of water, so 8 ounces every hour, and making sure they're at least drinking some glucose-containing fluids so that they can cover with insulin and therefore get more insulin to help treat the acidosis. If their ketones are moderate or large, we ask them to give extra insulin until their ketones are small, trace, or negative. And remember, if you're going to send them home, it's probably a good idea to call their endocrinologist, assure they're appropriate for home, and just to review their sick-day guidelines and whether or not they won't have any other recommendations. Patients are going to need to be admitted if they are in DKA and they're not corrected with ED management, or they're unable to take PO fluids and follow sick-day guidelines at home. And you typically are going to use an ICU if their pH is less than 7.1 or their bicarb is less than 15. If they're on an insulin drip, if they're really young, so less than 2, especially with new onset, and that's because, same reason for the next one, the severe hyperglycemia or hyperosmolality, that all puts you at a very higher increased risk of cerebral edema, and you need to have very close neuromonitoring. And obviously, if they have any abnormal neurologic signs or you suspect cerebral edema, they need an ICU. So our case, she gets a couple of fluid boluses and she's feeling better. Her labs and recheck show a bicarb of 18 and a glucose of 210, but she's still nauseated. She doesn't really feel like she can drink the amount of fluid she needs at home. So you decide, since her bicarb's 18, she can do subcutaneous insulin dosing, and you call the Peds Hospitalist, and you ask the parents, hey, when you go home to get your, pajamas and everything else you need for your overnight stay, can you bring back new pump sites and new insulin so the patient can be put back on their pump before they go home? So I want to cover some pitfalls and common questions we get from outside facilities that aren't common or aren't comfortable with treating kids. My patient's on an insulin drip and their blood sugar's dropping quickly, but they're still acidotic. Should I stop the drip? And of course the answer is no. Insulin and glucose are required to close that gap. So continue the drip even if their blood sugar's low, but increase your fluids with glucose. And this happens a lot where they'll stop the drip. My patient has one of those pumps and I don't know how to use it. What should I do? Ask the parent to disconnect or suspend the pump and give sub-Q doses. Call the endocrinologist, call the helpline, ask the parent or the kid. Kids are so good at technology. They probably know how to use that pump way better than we do. Ask them to help you. My patient presented in DKA and they're in hypovolemic shock. They're hypotensive. Is it okay to give more fluids than typical for DKA? Absolutely. Remember that shock treatment trumps all. If a kid comes in shock, focus on treating that first and then treating the DKA. These patients are always going to be very severe and needing PICU management as well, obviously. My patient's in DKA, but they just changed their pump site. Do they really need to change it again, or can I just give insulin through that? So no, you can't give insulin through it. Remember that if they just changed their pump site, that might have been what caused the DKA. So make sure they change all aspects of the pump site and get a new unopened bottle of insulin. Should I give bicarb to my DKA patients? I don't think many people are doing this anymore, but we still see it occasionally. So no, there's no clinical benefit, and there's several studies that say it might harm. So it increases the risk of cerebral edema, of hypokalemia, of hyperosmolality, and they get this paradoxical fall in the cerebral pH. So you're actually going to slow down their correction of ketosis. And do all patients with DKA need a drip? We talked about this. No, you can do subcutaneous injections for mild DKA. And if you're not sure, it's always better just to call your Peds Hospitalist or call your PICU doc and see what they think on whether the patient needs a drip, because you might save them an ICU admission. Here's some of my resources, and here's where I got all those fun pictures. And does anyone have questions?
Okay. So I saw one question pop up, but I'm going to go ahead and unmute the phone lines now. If you do not have a question or you do not want to make a comment, if you would just make sure your phone is on mute so that we don't hear anything going on in your background, I'm going to go ahead and open the phone lines in just a second.
The conference is now in talk mode.
Okay, so the phone lines are open. Again, if you would just mute your phone if you're not asking a question. Does any... That would be,
yeah.
Does someone on the line have a question?
I would like to ask a question quickly.
Okay.
Cara had said at the very end, say we're getting ready to discharge the patient. instead of chasing the clearance of ketones, that you could just add more insulin until the ketones clear? Is that something that we would kind of do on the floor to kind of help speed up the process to get the patients home and on their way? Thank you.
I think I missed part of that. You said, are you asking whether or not you can give more insulin on the floor to help clear the ketosis?
Yeah, that's checking the ketones until the ketones completely clear.
Yeah, so some institutions don't check ketones at all in the urine. They just go based on how the patient looks. But if the patient is having moderate to severe ketones like they are at home, we do recommend giving extra insulin. And the exact amount is going to depend on the patient. Typically a 10% increase is sufficient. So you can ask the endocrinologist, or you could look at their sick day guidelines from home and give that amount.
Hi, can I ask a question?
Yes, sir. Go ahead.
Yes, it's the same one in the chat. So can you talk about using lactated ringers instead of normal saline? Lactated ringers has the advantage of not causing a hyperchloremic acidosis, which would initially worsen.
Yeah, so you can use LR, especially if they're hyperchloremic to begin with. A lot of patients won't be if they do come in with vomiting and dehydration, but LR, you can use that if you feel it's appropriate.
Okay. Any other questions on the line or comments? Okay. Well, thank you all very much. Again, a reminder, if you want CME credit for attending this, click on the link in your calendar appointment. If you're listening to this live, if you're watching this as a recording on our YouTube channel, click on the show notes, the video notes, and you'll see the survey information down there. You can find all of our YouTube videos by simply searching Carilion Children's CME on YouTube. And with that, we thank Dr. Tillotson for her time, and we are going to disconnect the phone lines now. Thank you all very much for joining us.